Because we had a snow day today, I'm going to attempt a new idea here. Thanks to Jean Canty Schwartz for pointing me in this direction. And we're going to use Screencast-O-Matic to go through our lecture PowerPoint and to add some discussion. While we won't have time or the ability to do questions, please remember that you can send me a message on Moodle or email me with your questions. So, today, therapeutic communication. We are going to talk about how to develop a relationship with another person, a patient in the community, in med-surg and mental health. And what we're going to talk about are the conditions that are necessary for the development of the relationship and the phases of the relationship. To do that, we're going to use Hildegard Peplau's roles. She was the developer of a theory of communication that is still in use today. We're going to talk about the dynamics of the therapeutic relationship and how to use yourself therapeutically. So let's start with Peplau's roles for nurses. First, when she developed her theory, she described the nurse's role as mother surrogate, but today we would call that person the caregiver. It's not necessarily a mother. That person, that caregiver, fulfills basic physical needs for the patient. The nurse is also a technician who performs technical procedures for the patient, as simple as blood pressure, as complex as underwater chest drainage, use of a respirator, but nevertheless a technician. The nurse also is a manager. She manipulates, or he manipulates, the environment for patient improvement and safety. Nightingale told us in the beginning that cleanliness, comfortable temperature, appropriate diet, all of those things were the responsibility of the nurse and would help the nurse to maintain the environment for the patient's safety and improvement. We also are responsible for socializing the patient, for helping the patient, especially in mental health, participate in social activities with clients. We are health teachers. We identify learning needs in our clients and we teach them how to deal with the pressures of their disorder or of life in general. And we are counselors and therapists. Although a counselor or a therapist is generally thought of as an advanced practice nurse, the fact is that even at the very beginning of your practice, no matter what level it is, you will be counseling patients and you will be acting as an essential therapist, someone who helps them to communicate better with the world. One of the things you need to know about this is the difference between a therapeutic relationship and, say, a friendship. The difference is this. In a therapeutic relationship, it is your responsibility to assist the patient to bring about positive change in their life. It's, in other words, not about you. In a friendship, we exchange, we help, and we support one another. In a therapeutic relationship, our goal is to help the client bring about positive change in their life. So you will want to keep that in mind. Now, let's talk about the factors that can enhance your growth as a therapeutic communicator, because we have talked in class about this a number of times. First, genuine. The nurse is genuine. That means you're aware of your feelings and you are not distorting any messages. You're truthful. You're committed to your patient's improvement. You do not distort messages. You're straightforward. You are out there. In other words, you are able to be empathetic. Empathetic means that you can see things from the patient's perspective. It is not sympathy, which sympathy simply tells us, I support you, I'm so sorry for your situation. Empathy really shows how you feel what the patient feels. There is a YouTube video on the block on Therapeutic Communication on Moodle that you should watch in order to reinforce how to display and what empathy looks like. Another factor that will enhance your growth is positive regard. Positive regard implies that you respect your patient and you have suspended your value judgment. You have no judgment to make of the patient, and oftentimes that is a difficult thing to do. As you know, the common word we hear is that the patient is non-compliant. Non-compliant is, of course, a very judgmental term, and what it really means is the patient won't do what I tell him. But the patient is not required to do what we tell them. And so we need to think about how we feel regarding that value judgment that we are all sometimes too quick to make. We are also going to enhance our own growth by the development of the client's resources. In other words, pay close attention to the client's strengths, what they do well, what they need help with, where they are weak and need your support. Minimize that. Teach them how to support themselves to some degree. Take little steps in order to make that happen. We also want to make sure in the course of being genuine, in the course of being therapeutic, that we understand about boundaries. It is essential that you take care of yourself, that you protect yourself, and that you understand what barriers and personal space are, and that you are able to use them. We've talked about this in the class, and you've seen me put my hand up and say, stop, this is my personal space. I am uncomfortable if you come closer, but if you stay right there, we can talk as long as you like, that kind of thing. You have to be aware that you are required to help the patient grow by demonstrating what a boundary is, and that's how you do that. Demonstrate to others what is my boundary and how can I help you self-check and maintain your own boundaries. So when we talk about genuineness, empathy, understanding, etc., we want to look at several concepts, one of them being boundaries. Others of those concepts include understanding yourself, understanding your own values, your own attitudes, your own belief. It's always an interesting question to ask yourself why. We don't ask patients why, it's somewhat confrontational, but we can certainly ask ourselves, why do I have this attitude? What is it about this belief that makes me cling to it or makes me reject it? How can I open my mind just a little more so that I truly accept the different attitudes, values, and beliefs of my patients and my peers? Culture and religion. In mental health, religion is a big issue because religiosity is so often the cause of difficulty for patients. Culture also. Cultures look at mental illness differently. Some see the truly mentally ill, the schizophrenic patient, as actually having priestly powers. And they're very, very slow to criticize or intervene with the mental illness. On the other hand, other cultures are much different than that, and you will find the patient locked up in the attic somewhere. Not so much anymore, but for that, what we mean is hospitalized, dismissed by the family, put out of the family home, because our culture doesn't know what to do with that person. Social status is a very important tool to be aware of. There isn't any difference in percentages of people who are mentally ill when we're talking about social status. Just as many poor people suffer from mental illness as do wealthy people. Uh, the difference is often in the care they receive. I think you can look at that on your own. Gender, it depends upon the specific disorder, but again, treatment can be different for males and females, and we'll talk about those differences when we talk about specific mental illnesses. Age or developmental level, understand the differences that those can bring about in the patient's life. Um, for instance, we're not going to work with children, but you are going to see children in your practice, in the community, uh, in your neighborhood, and you should be aware that their developmental level affects everything they do. So we will have a guest lecturer who is competent and in fact has expertise in this area to talk to us about mental illness in children. We also want to be clear about our understanding of the environment. Who owns the space? In the milieu environment, we know who owns the space, don't we? If you don't, you need to look it up. How much space do you own in the milieu, in the society in which you live, in the classroom? How much space is yours? How about density? How many people in a space are too many people? Is it different for different types of people? In group therapy, what's a good density? Distance, we've talked many times about using space to communicate. And if you have difficulty with that, this is one of those areas that you ought to send me some sort of question or issue for discussion. And if you send it on Moodle, I'll open a forum so that we can see what we are all concerned about. Now, we need to also know what works. When you're working therapeutically to communicate with a patient, you are aware, I hope, that you have nothing to bring to the patient but yourself. You don't have a sphygmomanometer, you don't have a dressing set, you don't have anything, just you. And you come to the patient with a desire to help them bring about positive change in their life. Now, these listed items are the ways in which we do that. Consistency. We don't say one thing one day and one thing and another day, or even from hour to hour. We say what we mean, we stay with it. We pace ourselves. We don't rush through our interaction with the patient, and we don't drag it on forever either. We pace ourselves. We actively listen. What does that mean? We lean forward in our chair. We observe a good, healthy, open posture. I'll tell you more about that in a minute. We also try to give a positive initial impression so that the patient looks at us and is willing to give us a chance. We try to provide or promote comfort for the patient, a nice place to sit, maybe some privacy, maybe a comfortable chair. We develop trust how? By keeping our promises, by only saying what we mean, and by supporting the patient in their own attempt to enhance their life. We seek out active client participation. That goes back to what we were saying about helping the client enhance their strength and minimize their weakness, so that a client who is fearful of speaking to the doctor, while you will not speak to the doctor for them, you'll go with them when they go to speak to the doctor and be there as a support. That can be so helpful, as many of us know. When somebody goes with you to present some difficult suggestion or principle, it's good to have somebody there with you that you trust. Above all, we want to balance all of these principles together so that we come across holistically. If you have questions, don't hesitate to share them. This is the active listening slide, and it just tells you what to do to indicate to the patient that you are actively listening. Let me just say a couple things. First, it says to sit squarely facing the client. Not necessarily. You could sit at an angle. The point is that the patient should know that you are focusing on them, that the interaction is between the two of you. Observe an open posture. Simply said, it means that if you're in your chair and you're slumped back and your arms are crossed and your eyes are everywhere, you are not actively listening. You need to be leaning forward a little bit towards the client. Don't get in the person's face, but let them know that you're focused on them. Establish eye contact without staring. Many of our mentally ill clients become very distressed if they think you're staring at them. And the biggest thing that you can do for your client and yourself is to try and relax. Sometimes that's not easy in the beginning, but as you make yourself comfortable, make the client comfortable during the course of communication, you'll feel that you are indeed starting to relax. Now, let's go on to the clinical interview. First, we want to identify and explore problems relating to others. Now, this doesn't mean just in mental health. In med-surg, long-term care, peds, OB, whatever, you will have ample opportunities to identify and explore problems that relate to your clients. You're going to hear them, they will share them with you, you will teach to them, and you will discuss healthy ways of meeting their needs should that come about. You should try to help the patient experience a satisfying interpersonal relationship. And that means going back, emphasizing their strengths and reinforcing those, and minimizing their weakness, and demonstrating through your behavior and through your teaching how to strengthen those areas of weakness. The patient should feel comfortable and understood. Rarely does the mentally ill patient feel that anyone understands them, and it may be that you do not understand them, but through active listening, you will get better at it. Your mind will open to it a little more, and while you may not be able to grasp all the subtleties, you will get a better sense of understanding what is going on in the life of that individual. Speak briefly. The patient may not have the ability to listen to you go on and on. When you don't know what to say nothing. Silence is an incredibly important part of what you do. As you know in your textbook, there are whole lists of different forms of communication techniques that are therapeutic. My advice to students is to select 2 of them that you'd like to practice with and then add silence to that list. So that gives you 3 specific therapeutic techniques that you need to practice, and silence is sometimes the hardest. The difficulty with the others often turns out to be that, oh, well, when I say this, it sounds so rehearsed, or it sounds so stupid, or they know I'm making this up. I have to tell you they don't. Patients and friends and family really don't. Sometimes those closest to you, when you say something that is therapeutically positive, your loved one may look at you and say, "What are you doing?" Because they know that this is not the way you generally talk to people or to them. So practice the methods that you select and try to stick to them. It's better to know 3 of them comfortably than to be flitting from one to the other trying to figure out which one's going to be best. As you master the 3 of them, you can go on and add others to your repertoire. Always focus on the feelings. Um, Students will often say, I don't know uh, what to do about this. The patient told me this happened and I don't know what advice to give. Well, see what it says right here. Avoid advice. Always focus on feelings. What it must feel like to have that happen to you. What it must feel like to have a snow day and miss a lecture that you know is incredibly important to your instructor. And now what will I do? Because that can't be repeated in the classroom. Oh, look, she's going to offer it on YouTube. Perfect. So we can hear additional information. But always focus on feelings. We have no interest in the patient's medication regimen while we are communicating with them therapeutically, unless they complain about their meds and you want to say, well, tell me more about how you feel when you take these drugs, how you feel. Focus on that and you won't go wrong. Avoid advice. The bottom line, as you've heard me say before, is that nobody really wants your advice. What people really want is validation of what they have already decided. So just avoid giving it. Avoid relying on too many questions. Uh, Patients become uneasy, especially questions that begin with the word why. The word why is often interpreted as being judgmental, aggressive. It's often better to avoid that. Now, that being said, there will be many times that you make the error of using the word why, and remember what we talked about. That's okay. You can go back and fix it. What you really want is to be aware that you did it. And so you can say to the patient, oh, what I really wanted to ask you was, what was it that brought you to that spot in your life? Use another word and pay attention. Pay attention to what the patient says, because many times in discussion with students about their experience, I find that they have just wandered down the path with the patient, meaning they mean well, and they think they're paying attention, but they're paying attention to the wrong thing. So keep your focus on the client, active listening, and you're going to do fine. Now, let's move on. We have asked, one of the assignments that you're going to look at is a process recording. Um, there is an example of what this looks like in your textbook, and there's also the form for you to print out. And as you come to uh, psych, I will explain to you the details of what is needed. The difficulty often is for the first group or the second group, they don't even know what a process recording is. So in your work on therapeutic communication, take a look at the process recording in your textbook and the sample process recording. That will tell you pretty firmly what it is we're looking for. Now, nonverbal communication. As you know, we all communicate in many more ways than just the use of language. When we're talking about nonverbal communication, we're talking about physical appearance and dress. Note that when we go to mental health, we dress in street clothes and we use clothing that is casual but professional. Our goal here, we don't wear uniforms. This is very difficult for patients to deal with. And in the milieu, people don't wear uniforms all day. They wear street clothes. So in an attempt to create that environment, we wear street clothes. Our body movement and posture are important. Patients will watch carefully how you move, how you posture yourself. You want to have a flat affect, and you've all seen me demonstrate. No excessive laughter or smiling, just a flat affect ready to adapt your expression, your facial expression, to whatever the patient wants to tell you. Touch, we've talked about this. Patients in the unit, do not want you to touch them, make that assumption about all of them. If a patient reaches out to shake your hand, you may accept that and quickly let it go. Facial expressions on behalf of the student need to be, again, flat and neutral. Let the patient put a value on your facial expression. Facial expressions by the patient do not make assessments and judgments of what they mean. If a patient has a facial expression that you consider unusual or that requires comment, make that comment in a therapeutic way. I see that you are uh, laughing. Can you tell me what we're laughing about? Not I'm not quite sure how I want to put this. I'm hoping that you have a sense of what I mean. We're not going to talk specifically about the facial expression, but about the feelings that the expression shares with us. When I see you look like that, John, I feel like you must be very angry. And the patient will tell you what they think. Also, your eye behavior. Patients in an institutional setting really do not want you to stare at them, and they make the decision about what staring is. So while we make eye contact, we don't stare at the patient. Vocal cues, yes, go on. Certainly, I hear you. Mm-hmm. Those kinds of things are used to encourage the patient to talk with us about uh, what's going on in their life right there. So, nonverbal communication, very professional in nature, and part of this is also, I bring up again, watch your boundaries. So, okay, I've now figured out how I am to look, dress, and act, what's going to develop a relationship that's therapeutic. So, how can I effectively communicate with patients um, in order to make that happen? Well, first, we want to look at the different techniques available to us. And among those are the use of silence, which is on your right side. Silence provides time for the patient to reflect, especially the schizophrenic patient who could be very slow to respond. The reason for that is not that they are ignoring you or that they are incapable of response, but it takes a long time for the responses of the schizophrenic patient to work their way through the speech centers of the brain to this cortex, to the pathways that will allow them to say what's on their mind. An example is a patient that a group of students and I spoke to, and we wanted to see if he was able to interpret a familiar a saying. So the saying was, cold hands, warm heart. And we said to him, do you know what that means? If I say to you, you have cold hands and a warm heart, what does that mean to you? And we watched and we waited, and at last, I bet it was like a couple of minutes, and if you sit down and think about that, that's quite a while. He looked at us and he said, no, I have no idea what that means. So we thanked him for trying to work with us and we excused ourselves. I would say a good 15-20 minutes later, he came to seek me out, and he said, I figured out what that means. And so I got the students who were involved in this little project, and I tell us all. And he said, it probably means you have poor circulation. Now that is a sign of the concrete thinking of the schizophrenic client, and it tells us so much about the progress of his disease, and it tells us that he does have the ability to try to think and to develop an answer. The reason that happened is because we allowed him lots of time to come up with it. we were silent and we allowed him to reflect on the issue, and he came up with an answer. Now, it may not have been the right answer, but that's not the point. The point is that in hearing his answer, we learned something. We learned that the schizophrenic client is incredibly concrete in his thinking, and there's something we can add to our knowledge basket. Active listening, we already talked about. Listen for false notes. We don't call them lies because often because they're not lies. They're just the way that the patient sees the world. Look for context. Does it all kind of fit together? And provide feedback. And I'll tell you about that in a minute. When you look at the different kinds of therapeutic communication, I've listed for you here one, two, three, four, 5 types that I think you should look at. And while I've said that you could choose 2 plus silence to emphasize, these are the ones that I think are most useful to new students. Offering self, especially exploring, reflecting, paraphrasing, clarifying technique, and be open-ended. Open-ended questions are those which end with an opportunity for the client to talk about something extensively. Close-ended questions are those that end in yes or no. I also try to avoid judgmental statements. I almost never say good morning to patients because that's a judgment about their day that I'm not inclined to make. That might not be a good morning for them. Little things like that are very important in the lives of people who are struggling with mental illness. So I ask you to look up the techniques I've listed here and decide on which ones appeal to you. Now, it said in the previous slide that we're going to give feedback, and we are. But first, we need to know what feedback is. The purpose of feedback is to impart information, not advice. You'll hear me say that a lot. No, we don't give advice. Nobody wants it, and we don't give it because it's just not helpful. And it's always better if I think people come up with their own ideas. However, we are certainly free to ask, well, what have you been thinking about this issue? What have you been feeling about what to do here? Also, we describe our patient. We don't evaluate him. When I see that you are unwilling to sit down with me, I wonder what that means. That kind of thing. Focus on the behavior. That's the same thing. When I see that you are unwilling to walk with me and you seem upset, I wonder what that means. Feedback is specific. It's not general. Gee, sometimes you seem pretty unhappy is not therapeutic. What is therapeutic, however, is something like, right now it seems to me that you're feeling unhappy. That's it. Feelings, a statement that describes what you think you see, focuses on the behavior, not the client. It's specific, and it has to be directed toward behaviors the client has the power to modify. Let me give you an example. There are medications, not so much anymore, used to be far more common, that cause a side effect called tardive dyskinesia. And when the patient gets that side effect, you can't fix it. They will make odd movements with their tongue and their lips and their face. They are neurologically incapable of fixing that. And so it is pointless to say to the patient, I notice that you have a great deal of difficulty keeping your lips and tongue in the proper position. What can we do to help you with that? Nothing. Before you move to the behaviors that the patient may be able to change, make sure you know what's causing them and if it has been addressed in the past. Obstructive techniques, and we do this every day. Everybody does this. I can't even begin to list the mistakes I make. But what we do know is that we can fix them. So, what are the obstructive techniques that are most distressing? Excessive questions, especially the ones that are closed-ended. Well, did you take your meds today? Well, when did you take them? Well, how have you been about doing that? Well, what do you think is going to happen in therapy today? Or do you want to go? Did you go? Why not? You become their interrogator, and that conveys a lack of respect. So just be careful to balance your questions with your concerns about their feelings. Also, giving approval or disapproval is simply not helpful. Oftentimes, students will think, well, if I give approval, that's a good thing. But in fact, it's a judgment, and it cuts off any further communication. Good morning. Well, you look great today. I guess we're done here. I guess there's nothing more to be said now. You wished me a good morning, and you said I look great today. Well, the fact is, I look terrible today. Can't you see? Evidently, the nurse cannot see. These kinds of verbal exchanges that we go through every single day with so many people in the mental health setting are very, very obstructive. We've talked a lot about giving advice. Instead of giving advice, encourage the patient to solve their problem and to look for underlying motives about why they are seeking your advice. What is it they really want? What is it they really need? Most of the time I find that what the patient needs or wants is validation of their already made decision. Don't give that. They need to be the ones to decide. And the same is true actually in your personal life. When people begin to ask for your advice, you want to be very, very careful what it really is they're asking for. And as I've said, why questions? Why questions imply, first of all, criticism, and even more interesting, they lead to rationalization. Why do you think you feel this way? Well, I feel this way because blah, 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 blah. And then on they go about why they feel that way. All of it rationalization. The bottom line is, I see that you are feeling angry. Can you tell me more about that? Now, let's take a look at the defense mechanisms that we're going to see in the patient. We've reviewed, or you have reviewed, defense mechanisms in a number of different places, and you might want to go back over them again. Although I've only listed a few here, the fact of the matter is that as you progress in your practice, you are going to be needing to know more and more about those things. So take a look at the ones I've listed: displacement, transfer of emotions to others who are safer, so that you come up to the nurse manager and she yells at you and you go home and you kick the dog, or you yell at your children. God forbid you should kick the dog. You go home and you yell at your children. And all of us know what that feels like. We've been made angry, we've been embarrassed, we've been upset, and we go home and we take it out on someone who's weaker than we are, who's safer. Projection, very interesting mechanism. What we do is we take all of our own unacceptable features, and these are unconscious. These defense mechanisms are always learned very early in life, and they are always unconscious. So we take these features that we find unacceptable in ourselves and we give them to someone else. We say, oh, she's such a liar, or she's so untrustworthy, or she never finishes what she starts, or this or that or the other. But if we were able to truly open our minds, we might have to say, well, sometimes I don't tell the truth. Sometimes I don't finish what I start, etc., etc. That's projection. Denial, of course. Escaping unpleasant realities by ignoring their existence. A friend passes away and you don't want to tell anybody about it because it's just too hard. The truth is that not telling anybody about it allows you to continue your denial. We're also going to talk a little more about passive-aggressive behavior and how to use some of these defense mechanisms and how to recognize them in your client. First, the passive-aggressive patient is in their unconscious mind believing the following: the only way I can preserve my self-respect is by asserting myself indirectly. For example, I will not carry out instructions exactly as given. There will always be just something a little different about the way I respond to instructions. This is unconscious, and it's important that we recognize this, that this individual is not deliberately going out of their way to cause a problem. They simply feel that they cannot maintain their own self-respect by being open. They feel, I like to be attached to people, but I am unwilling to pay the price of being dominated. In other words, I want to have close friends, I want to have a partner in life, but I get very anxious and upset if I think they're trying to dominate me, and they almost always are. This is the thinking of the passive-aggressive personality. They almost always are trying to dominate me, and while I want to be their friend and I want to be involved with them, I don't like that. Nobody likes that. What's important is the way we respond to that. Authority figures, they are intrusive, they are demanding, interfering, and controlling. Authority figures and our response to them depends upon our own experiences of life. Everyone from time to time thinks of an authority figure as being demanding, intrusive, interfering, and controlling, but that doesn't mean that we continually think that. Most students, for instance, in beginning this program in 107 Lab, were very uncomfortable with faculty observing their skills, very uncomfortable with faculty in the clinical area watching how they were learning their technical skills. That's difficult for most people. That's difficult, but you come to understand that in nursing, everybody does. That's the culture. In order for me to be sure that you know what to do, I want to watch you do it. Then we both know. The passive-aggressive person will believe I have to resist the domination of authority, but at the same time, I have to keep their approval and acceptance. I want them to like me, but I can't let them dominate me, and I am the one who decides where that domination is. I decide that. So that's a hard way to live your life, but many people do. What can we say then to look for? Well, passive-aggressive individuals have a lot of trouble making deadlines. They're perpetually late because they can do the assignment, and you know they can do it at an A level. But in order to let you know that they're not going to be dominated by you, they turn it in a day late. They're still, it's just the way it is. They have great difficulty complying with demands. Any kind of a demand is a direct blow to their pride and self-sufficiency. And so they manipulate that, what they consider a demand, which may be a request that's being made of everyone, but they take that very personally. They believe that it's best not to express my anger directly, but to show my displeasure by not conforming. I know what's best for me, and other people shouldn't tell me what to do. Now, if you look at that, you will find that many of your patients, in fact, are dealing with that when they are ill because they feel so out of control. as you progress through your practice, you will become better at acknowledging this personality issue in the lives of others and even in your own life, because all of us have passive aggressive days. All of us do that. But we should try to work to be aware at why the patient never keeps the appointment, why the patient refuses to take their meds. It isn't that they don't want to, it's that they can't. These are unconscious things that go on in the client's mind, and we want to avoid, if we can, any kind of judgment. Although I have to admit that sometimes the passive aggressive personality can be quite upsetting. All right, so here we are with our client. What do we do then? What do we do if the client cries? If the client cries, we stay with the client and we reinforce the client's right to cry. We certainly do not say, oh, now come on, stop crying, everything is going to be all right. We certainly don't do that. But we sit quietly with them, and by sitting with them, we are showing them that we support their right to this kind of emotional expression. Asking a secret, we already talked about that in the last class. You cannot make this promise if it involves danger to self or others. In addition, sometimes you have to really give thought so that if the patient says, well, I want to talk to you, but I want to make sure you're not going to tell this to anybody, you might feel comfortable saying, well, I may have to talk with my instructor about this because this is for my learning, and for learning purposes, that's the person I go to. But I don't have to tell anybody else. And I may not even have to tell her, but I need you to know ahead of time that might turn up, and then you can decide what you want to do. What if you are talking to the patient and they get up and they walk away before you're finished? They just don't want to do it anymore. Well, you sit where you are. You just sit there. Most of the time, your best bet when you approach a client is to let them know, I have 10 minutes, I have 5 minutes, and I thought we could sit and talk. And if they agree, then you sit there. If after 2 minutes they get up, walk away, and leave you, you sit there for the other 3 minutes, because that's what you gave them, 5 minutes. And if you watch carefully, you may see that the client, in fact, is walking back and forth to see if you are still there. Now, your 5 minutes goes by and the client comes up and says, well, I'm ready to talk to you now. The correct answer to that is, I'm so sorry, John, but our 5 minutes is up. However, we can make another appointment for 5 minutes this afternoon. In this way, we help the client structure his day. We help the client to see that we have boundaries. That's another way to show the client, I want to meet with you. However, this was the boundary that we set. These are very simple things, but in the life of the mentally ill client, it's very helpful to do this for them. Now, what if you're talking to a client one-to-one and another client walks up and wants to just hang out with you? You have every right, and in fact, the client you're with will feel very comfortable hearing you remind the intruder that this is your time with Mr. X. I'm so sorry, John. Mr. X and I have another 4 minutes together, but if I can see you at 2 o'clock for 10 minutes, and I would like you to excuse us right now. You have every right to say that. Responsibility is on you to help the client, who has very little, if any, ego strength to create space for himself or herself. The client who says she wants to kill herself, the first thing we do is we're going to have a thing on suicide, so we'll talk more about that. But sometimes the client, remember what you've said in your I cannot keep a secret that relates to danger to yourself or others. And you can, if they say, well, the fact of the matter is I'm sick of this and I'm going to do away with myself. You have the responsibility and the right to say, well, actually, that's something I have to report right away. As we talked about in the beginning, that is a promise I cannot keep. But before I do that, can you tell me if you have a plan? And then you begin to talk with the client about their plan. If they're in an inpatient setting, no matter what the plan, it's not very lethal because they're not going to be able to do much. But if you're not in an inpatient setting, lethality becomes crucial. So there's a big difference between I have a gun in my car and it's loaded, and as soon as I can get out there and get it, I'm going to kill myself. That's a lot different than, oh, well, I have it all figured out. I'm going to go up to Boston. I'm going to get a hotel room. I'm going to get illegal drugs, and I'm going to take an overdose, and I'm going to do this on my birthday. And then my mother will see. That kind of thing. Well, that's not a very lethal plan, and so it doesn't carry the same weight as the first. So make sure you first and foremost assess the lethality of the plan. And the question that leads to that when you speak to the patient is, do you have a plan? And that's all. And they'll tell you. Now, what if the patient says they don't want to talk to you? Just sit there. Just sit there and say to them, that's fine. We don't have to talk. I'll just sit here with you for a while. And that's what you do. Now, let's talk a little bit about the adaptation to anxiety. I have questions here, and those questions I'm not going to answer for you. I would like you to email or send me a message on Moodle. In fact, what I should do is open a forum. Give me to the end of the day or tomorrow. I'll open a forum for the class, and you can submit your answers to me. The questions: an elderly client lives alone despite a severe right-sided weakness that makes ambulation difficult and household chores almost impossible. So what mechanism might she be using? Interesting question. And then you would look up the answers, of course, and choose the one that you felt was most likely. The same with the second. Anne's husband complained about her cooking. Anne left the table, went to her craft room, and spent 20 minutes using a hammer to make a wooden bowl. Her behavior demonstrates what mechanism? After a terrible day at work, Jean goes home. She finger paints with her preschool children. What might she be demonstrating? And Ginny, the supervisor, tells Joan to do several additional tasks. Joan asks Ginny, why do you dislike me so much? This question stems from, there you go. And the last one, Jack failed his nursing courses. He withdrew from college and took a job. Later, Jack has no memory of this college experience. He may have used the defense mechanism of. Now, I have to tell you, that's very unusual. That doesn't happen. But I will tell you an example that does happen. When for some years, well, for many, many years, my current husband has been the repository for my memories of my life with my first husband. After his death, which was extremely sudden, although I went on living my life, I really didn't remember a lot about what happened while we were together and while I was raising my son after his death. And thankfully, Bob remembers all of those things, and he helps me trigger those memories, which are really good memories, which I enjoy hearing, but which at that time were not good memories. They caused me too much pain. Now everything is different in my life, and they're fine. So be aware that although the description given here is an unusual one in terms of questioning, this is a mental mechanism that does occur. Now, we've been about 1 hour at this. That's really neat. You figure the break, you figure time for question and discussion, that fills our morning. I hope that this has been helpful to you. Once again, I thank Jean Canty Schwartz for pointing me in this direction, and I look forward to your feedback. Look through the presentation and tell you what feedback is, and you can try it. Also, there is an outline form for this presentation, and there is the original uh, PowerPoint form that I would have offered had we been in the classroom. Um, I wish you a good day, and I'll see you next week. Thank you.